Good morning, everyone. Welcome to Coffee and Cases. This morning's session is sponsored by Stat Medical. So just a big thank you to Stat for the support this year. And if you're looking for any kind of EMSC stuff, please just pop onto their website and go and have a look. Today's session is going to be presented by Karine, who's doing her PhD on some of the cool stuff she's going to speak about today. And we're really lucky to have her come and share some of her ideas and thought processes. Just a few reminders before we start. So it's a super safe space. The idea is really to generate some conversation and to chat about some things that are maybe difficult or interesting to many of our environments. We really want to try and break down any silos. So hopefully we'll have some people speaking from the EMS space, from the hospital spaces, from the ICU spaces. Everyone's welcome. Everyone's ideas are valued and useful. And then just another reminder, please don't put any of your details into the chat. We are going to be sharing a link with the registration, and you'll be able to get your CPD points on that. If you do have any questions, please pop your hands up. It is difficult for the presenter to see, but I'll try and highlight as we go along. Karine, up to you.
Thank you. Good morning. Can you hear me?
Yes.
Thank you so much. Thank you for the opportunity, Caleb. Always an honor for me to present on this forum. So thank you very much for the opportunity. Okay, as Caleb had said, please pop your hand up, or if I seem like I'm ignoring you, please alert me if there are any questions in between. You're welcome to stop me as we go along. Okay, so my background, Caleb had mentioned most of it, and just to give you more background, I'm a fixed wing flight nurse for Air Rescue Africa. And this talk I did at our flight meeting last week, and it's sort of based in the aviation space for critical care transport. My PhD is specifically on resilience in critical care transport professionals. So this is born out of it, something that I've always heard a lot about, but I felt like there was nothing concrete said in it or sort of pinpointed out to me. I've listened to a lot of podcasts. I love the topic. I love it. One of my previous bosses used to say, it's very kumbaya, but let's put it into some summarized pointers and see how we can make this work in our specific environment. I've recently listened to the book by Stephen Hearns again, Peak Performance Under Pressure. An amazing book. I can recommend it to anyone. I'll share it with you guys on the chat. I've listened to it on audiobooks. And again, like I said, I listened to some podcasts, and I wanted to elaborate on this more. So the aim was to understand what human factors are and how it influences us, and how we can use it to better our environment, to promote safety for us and the patient. Just some disclosure, there's no conflict of interest, and all the pictures shared today is with consent of the particular faces. You might recognize some people. So thank you. Just confirm that it's jumping to the next slide, Caleb.
Yes.
Thank you. Good. So some definitions. What are human factors? So and when I read these two definitions, you want to look at the highlighted ones, that the words jump out to you when you read this. So human factors encompass a broad discipline that examines the interactions between humans and the systems they operate within. In healthcare, human factors involve understanding how the system design, human behavior, in the environmental influences affect performance and safety. So the words that jump out to me is safety, environment, and then to support the human in the specific environment. Just some background, how I see it. When something happens, there's an adverse event in a system, maybe with the critical care transport of the patient. What happens is we debrief it. We look at all the points, what had happened, how it had happened, and why it happened. And then we write a policy to improve the system, or that's what should happen. But does this help the human behind the error? We need to remember that it needs to improve the system to fit the human and not the other way around. For example, there was a new university built in America, and they had these little courtyards that they had up with grass everywhere, where the students would walk around or on the grass. And they had these beautiful pathways on the grass, and the students would walk on the pathways, but not only on the pathways. So they would walk off the pathway and kill the grass. So they would be pathways with cement, and some that were human made. So what they then did when they created new courtyards is they had the courtyards with lots of grass, and then they let the students and the people at the university walk wherever they feel fit and comfortable and safe. And then what they did is after these little pathways were created by the human feet, then they laid the cement. So this is a perfect example of how the system was created and changed so that it fit human behavior. And I want to just pull a golden thread through it all. As long as it's safe, we must remember that it has to be safe for us and our patients. So change the system so that it fits human behavior. Okay. Some background to my environment. So we recently obtained an autopulse. Thank you, Stat Tekeni. Some acknowledgement to them. And we want to set it up to use it in our environment. And when you look at the podcasts and the YouTube videos out there, it's with two rescuers, and you have access with a patient from both sides when you need to insert this device underneath the patient. But in my environment, it's a fixed wing aircraft. You'll see there's fuselage on the one hand side next to the patient here. So it's impossible to have the healthcare professional on the left-hand side of the patient in this instance, for example. So what we did is we played around. We had the autopulse in the aircraft, and my colleagues and I sat the patient up. We played patient, set it up, put the autopulse in, see how it's humanly and ergonomically safe and convenient for us. And then we wrote our policy. So we didn't look at the YouTube videos and go, oh, that's how you have to use it. We made sure we can use it in our environment, and then write our policy after that so that it suits the environment. I want to also point out to make sure that we actually don't become dinosaurs. So I've been in this environment many, many years, and the theme that's come up for me is that I want to prevent from becoming a dinosaur. And what I want to mean by that is, don't fall into the pitfall where you say, oh, but this is how we've always done it, and this is how it will be done. Be cognizant and be aware of people that come into an environment, are brand new, you think they don't know a lot, but they often walk into your space and go, why are you doing it in this way? Listen to what they have to say. If it is safe, again, the golden thread, if it's safe, listen to it and maybe change the system so it suits how you can function optimally. This specific case, it's a patient we evacuated out of Africa, and you'll see this is the ground ambulance. So you'll see it's not a I shouldn't say it's not safe. It is safe. We ended up moving the patient in this vehicle, but when this ground ambulance arrived at the on tarmac when our aircraft had landed, we had an observer with us. So it was two permanent flight nurse and a flight doctor, female, and we'd flown for years. And the observer, it was his second observer that was with us. Thank you, Yaku, a recognition to you. When the ground ambulance drove up to us, and they opened the doors, and we looked in the back of this, and Francis and I just started putting our equipment inside the aircraft, into the ground ambulance. This new observer, Yaku, looked at us and he said, how do you guys know that this is the correct ground ambulance for us? And Francis and I, the oldies or the dinosaurs, we looked at each other and we went, we never questioned this. Again, it wasn't unsafe. And I mean, they'll have permits to come into the apron. So there is some policy and procedure in place. But is it a question that we should ask because of safety for ourselves, for example? So just keep that in mind. When someone new steps into your space and they question something, don't dismiss it. Listen to what they have to say. They look at it from a different perspective, and they often bring with new knowledge that we don't think about because we're so used to, and we've become so complacent in our environment. So question the status quo. Good. I've broken it down to 5 numbers, and we'll discuss each of them just to break it down and to make it a little bit more simple and make it a little bit more concrete for us. So thank you. Human factors and ergonomics. So a little bit of background. Ergonomics is derived from the Greek word ergon, and ergon means work, and nomos, which means natural law. So it's the natural law of work. The complex interactions of the human and the system that it functions in. So the who are the people that we work with. That encompasses us as the critical care transport professionals or healthcare professionals. And the what are the tasks and the processes that we have to do. So what do we daily do? The how are the tools and the equipment that we use to get our jobs done. And the where is the clinical environment. So for example, in my environment is a fixed wing air ambulance, but also the wider environment. So my governing body, I fall under international SOS. I fall into a country called South Africa and the greater continent, Africa. And all of these things bring their own, I don't want to call them challenges, but their own unique characteristics. So we need to be cognizant of that. What does that patient that I find in Africa bring? There's a language barrier, there's a racial barrier, there's the traditions that they have. I think, for example, specifically when we fly into these countries where viral hemorrhagic fevers, for example, Ebola, are very, very rife, we come in there and we just take these sick or dead patients from them, or bodies from them. And what do we do with them? We burn them because that's the safe thing to do. But do we keep in mind what their traditions are? Do we keep in mind what they for lack of a better word, but in their tradition, what are their cultural beliefs that they do? In the countries, for example, in Sierra Leone, when someone dies, doesn't matter from what disease they die of, the belief is, and the traditions are that the whole community come together. They actually disembowel this body and they wash it, they put it back, and then they bury the patients. So you can imagine the health risks that are involved with that. Is if someone has Ebola and even days after that, they disembowel them and wash them, everybody gets exposed. And we come in there and we're the saviors of the day, and we just remove these people. They don't have time to grieve. They don't have time to give, they pay their respect. So keep in mind where you go to. You step into a little hut, anywhere in South Africa, never mind in Africa, keep in mind what their religions are, level with them, understand their traditions, and understand their languages. I know it's not always possible, but be sensitive to that. And then the bigger governing bodies, for example, in South Africa, the LIFEs and the Netcares, there's policies, there's procedures that work with that. There's socio-political environments, things like patient-nurse ratio. All of those things are our way that we find ourselves, that we work in. Just a bit of background on Hippocrates. We all know the big guy. So in my view, he was the first one that described what we would call today the grab bag. So he, in the 5th century, he described how surgeons should lay out their tools to maximize their surgery. So if you think about it, how, and I invite all of you that love to come and see our setup at Air Rescue, we've actually been lucky that we've moved around quite a bit, and we set out our bags that when you resuscitate in an aircraft, it makes the space and the system conducive to how the human, as the healthcare professional, will resuscitate or do procedures on our patients. Okay, so think about that. You need to, the safety must be first of all, and then change your SOPs so that it fits the human behavior. Okay, the name. So some people describe human factors as the reason why something had gone wrong, or why humans had failed, or the human factors got in the way. But that's actually not what it is. There is an overlap between non-technical skills, being a subset of human factors, focused specifically on interpersonal and cognitive skills, or human factors, but takes a more comprehensive view of how the system and the elements influence humans' interactions and the outcome in healthcare environments. Incident analysis most or often show that there was a lack of communication, and literature shows that as well. So what we do is we debrief, we write it, we think about it, what had gone wrong, and what do? We write a policy. This does, however, not show that it's usually the weakest suggestion. So make sure that your policy, if it is safe, suits the environment. Why did those healthcare professionals, I wouldn't say fail, but why was there an incident? We have had an example, and in our space, and I'm sure that in the bigger environment, we're lucky enough that there are safe space. When something happens, for example, when scheduled drugs break, question the system. Is the box that it's kept in, is it safe? Is it adequate for what you keep in that box? Do not just blame the healthcare professionals behind it. So blame the system and look to change the system and better the system. Good. There's often comparison between aviation and medicine, and it's not always a great comparison, but there are some overlaps. And in my specific environment, we're actually lucky because it does marry the two, the aviation and the medicine compartment. The difference is, however, when pilots go through their checklist and there's too many red flags or non-flight tick boxes that were ticked, they won't fly. We, as healthcare professionals, will still go and save the patient. We still have to go ahead and treat the patient. So we can't just say, oh, I can't touch this patient because he's too ill. We need to educate the people, or we try to educate the people and not the system. And remember, like I said, it should be the other way around. Humans are resilient and humans are not flawed. It's a system that's flawed. That's why things go wrong. So question it. When you investigate why was there an adverse event, it's the system and not the individual. Like, for example, like I said, in the aircraft, think about the space that you need to work in, that you need to do an ultrasound in, that you need to put a line in. How can you optimize that space? And you think of this aviation environment that would work best and better for the human, also for the patient, but for the healthcare professional behind it. Expect the unexpected. So this is my number 3. We try and constrain and contain unpredictability. We introduce rules and protocols and standardized procedures. And from that paradigm, any deviation is seen as dangerous. But in our environment, we all know change and variability is inherent to it, such as healthcare. And when people don't do what we want, we try and educate them to do so. And we use policies and procedures then to sort of force them or to do things that we want them to do in a certain way. And a very, very practical example that you guys are all aware of, I don't know if you've noticed it. So in the past, when you go to an ATM machine, lots of people would forget to take their cards. They will take their cash and then walk away without taking their card. And then they try to educate the human behind that error. So they had flashing lights up, they had big little arrows pointing to your card exit port on the ATM machine, thinking, please take your card, please take your card. Even on the screen, there would be flashing messages that come out. So what they then did is, as long as it's safe, they changed the system. So you'll note when you go to an ATM today, you can't take or receive your cash unless you have removed your card from the machine. So please today, when you go to an ATM machine, when you take cash out, note that you will take your card first, and only after you've taken your card will the cash be given to you. So that's a perfect example of how the system was changed to safely guide the human and not the other way around. And once you that penny drops, and once you get it, it's actually quite too intuitive. It's baffling actually, because human factors bring to us the conscious, what do we actually do on autopilot is to actually consciously think about why we do it, and then to teach us on how to do it safely. Intuition is so what is intuition? Intuition is years and years of practiced experience and experienced wisdom. It brings to mind the mindset of why are we doing things in this way and how can we better it? So policies and procedures should be a scaffolding rather than a cage. When people are not compliant or they are resistant, the question should be asked whether the work that's being done is actually the work that's being prescribed. So do they always take a shortcut, or is it because the policy or the procedure is not written the way it should be safely or is safely done? So think about that. And does the system actually support the human? Remember, as long as it's safe. So this was a case that Ulrich Karsach, and those who know him, that we flew out of Africa again. On the left-hand side, that's the picture that we were presented with. That's our ground ambulance. And unfortunately, that's all we could get. So, I mean, you have to make it safe, first of all, like remember the golden thread. But what we then did is, you'll see on the right-hand side in that picture, this gentleman luckily was not intubated, so he was sick, but not too sick. And we could secure him, number one, properly. You'll see there's a mattress underneath him. Our vacuum mattress is nicely secured around him. And he is secured onto the ground ambulance stretcher. That's actually not a ground ambulance stretcher, let me just point it out. So that is a hospital trolley, looks like a theater trolley that has brakes, number one, and we could safely transport this patient. But again, you need to be open to change and variability as long as you stay safe, because in our environment, things change all the time. So just keep that in mind. Good. Humans are our greatest asset. clinicians and humans are the things that saves us. We are able to change and we can adapt, and not AI and not policies and procedures. There's a beautiful story about this drawing into intuition in this number 4 as well. There's a beautiful story about a firefighter chief that he had all his men inside this house, that they were fighting the fire from a kitchen. And they were trying to kill this fire and trying to kill this fire, and it actually didn't work. And he ended up saying let's just debrief. Let's do a bit of a almost like a 0.0 survey. He called all his men that he had in the house at that moment into the living room space, and let's just reassess. And while this very experienced fire chief stood in the living room with all his men, he said he had a hunch. His intuition said to me, we need to evacuate. We need to get out. He evacuated everyone, and minutes after that, the floor that they were literally standing on minutes before collapsed. And they would have died if they were still inside that living room space. And then what they did is, after this incident, luckily no one got hurt, they debriefed the firefighters and then also the fire chief. And he said he had a hunch. There was something that said to him, we're not safe, we have to get out. But what they then, after debriefs and some in-depth discussion about it, he then mentioned that there were a few things that stood out to him. So first of all, the fire was very quiet. And second of all, it took them too long to be able to kill the fire. And the fire was a lot warmer than normal. And what had happened after investigation, that the fire was actually underneath the house and not from the kitchen that they had originally thought. And because of these little micro I'm trying to think what the word is that I used here. Sorry. The micro cues that the fire chief had picked up, because of years of an experience and his intuition, he was able to save all his men. So that's a beautiful story on how intuition, we think it's just a hunch, but it's actually years of experience that make you pick up on these micro cues that you see around you. That's the gut feel that we talk about. It's me as a nurse would say, like a nurse consider that maybe the patient is not doing well, plus their experiences, and it can actually predict clinical deterioration. And it's practiced wisdom that is called intuition. The 51% that I refer to there is specifically this intuition that you have. In the HIMSS environment specifically, they talk about where there's a 51% rule. So when there's 3 a pilot, for example, and then 2 critical care transport professionals, or maybe 2 pilots. When all of them do the weather assessment and they look at it, there's some danger, it's a little bit overcast, but they say there's still a go ahead. If one of the people in that team that are supposed to fly today feel that it's not safe, that person, whether it be the nurse, the doctor, the pilot, has the 51% rule. And if they deem it's unsafe for whatever reason, I mean, it shouldn't be a hunch or something that's not really grounded, but they have that hunch and they have a 51% rule, say that we shouldn't safe. Let's discuss this properly. I feel like it's unsafe and why, and then they discuss it before they just take off and fly. So briefing, number 3 there on circle on my slide there, briefing. We brief lots, and you need to be able to understand what the importance is of it. We always brief the incidents or the things that had gone wrong, but we need to be cognizant of it and not be lazy with our briefs. We shouldn't just brief these incidents. We should actually brief to check in with each other as well. And what I bring into that is we all bring human factors. So we fly with families in our backgrounds. I have children. I fly with a sick parent that I have in the back of my mind. I could have, as a healthcare professional, have a partner is pregnant at home. And all of these things we bring to work, even though we leave it at home. But when I know my healthcare professional partner, my crew member today, has a sick child at home, how can I make it easy for him? Should I wait until he sorted out his house, make sure that his wife is okay, or his husband or her husband is okay? So keep that in mind, that when you come, and be be honest about it. Say that today I'm having a bad day. I didn't sleep last night. Maybe I can sleep the first part of the flight or the empty leg of the flight. So be cognizant of what you as a human bring. And that is part of your brief before the flight. So you brief what you're going to fly with the patient, but also check in with each other. And then on debriefs afterwards for cases or for flights or incidents, we should also debrief the mundane. So what had gone right? So that we can learn from it. We should have those briefs or debriefs afterwards so that everyone else around us can also learn from it, that what had gone right and not just what had gone wrong. So number 5, it is, again, to bring back, how do we use this to improve our work? The who, and I've touched a lot on this already, but remember that human psychology is flexible. We do what we think is right, and we actually go about it unconsciously. So we need to think about it. Why do we do it? Unpack it in a conscious competence so that we actually understand why we had done it. Think about the people that you meet there. Like I said earlier, there's lots of language barriers, there's traditions. Keep in mind all of that when you fly and fetch a patient or touch someone in the hospital. What do they bring? What do they bring with them in their heart, and not just physically as a visitor next to them? The procedures, like I said, that we would like to accomplish. Say, for example, with intubation, how do we allow the different pieces of equipment to be laid out in your bag, in your system, in your ED department, in your theater, so that it optimizes the ergonomics on how you're going to do it. Make sure the devices are checked, make sure that the devices are serviced, make sure that the devices are safe to use, and it actually is for that specific patient. You can't have an adult laryngoscope for a baby. So remember that all of those things make it easier and safer for us. How, like I said, again, the equipment be flexible, devices can break and devices can be discontinued. So keep in mind that you need to make sure that you actually, can you guys hear me?
Yes.
Yes.
Oh, I just had a power failure. I just want to plug my screen into my backup power. Can you guys see my screen? Let me do this.
Yes.
Can you still see my screen?
Yes.
Okay, brilliant. Okay, then I'll continue. Apologies. Okay, let's just continue. I can still see what I need to read. Thank you. So just to go back to the who. Okay, so when you get stuck in, remember
the screen is going black now.
Okay, hold on. I'm just going to plug it into my backup power. Give me 2 minutes. Okay, you should be able to see it soon. Just confirm with me, please.
Nothing as of yet.
Oh, good. Okay, brilliant. Thank you. Luckily for backup power. So I'm out in a...
Nothing yet.
Nothing yet. Oh, okay. Let me do this. I'll continue talking because the slide hasn't changed, but I'll continue talking while we wait. I'm not to waste some time. Going back to the where, like I said, where we find ourselves, the environment and the space that we find ourselves in. The emergency department, the hospital we find ourselves in, the clinical environment, the actual government we find ourselves that we work under, our health professionals council, our nursing council that we have to function under. Keep all of that in mind because that is where you find yourself that you work in. Like I said, the environment changes as well, and you need to be able to adapt to it so that you can actually use different devices, different setups. It's a little bit like learning to drive a car. It's good to be able to drive stick, but if you suddenly have to drive an automatic car, does it make you better? it's good to know your equipment, and that's the equipment you use in your environment. But if you are faced with a different laryngoscope because yours that you always use is broken, be able to change and adapt to that. But then, yeah, I've got some pictures. You guys, can you still not see anything?
Nothing yet.
Yeah, let me do this. Let's see when I share. I'm not the best of drivers, so apologies. Go. I think I'm sharing the wrong side now, but it doesn't matter. Let's just continue. I'll read the rest for you out loud. It's fine. Okay, so I've got pictures up there of some of the people that I work with. And I just wanted to confirm or sort of elaborate on what you bring to the party, and what you have to remember that is someone else that they would bring, those human factors that they bring with us. The idea is then to summarize all of this and to combine all of it so that you actually optimize it, and again, for safety for your patient. And I want to end off with a letter that a dear friend of mine had shared with me. She's a doctor as well, and she had written this after she herself had a intercostal drain put in. And the way she describes it, I want to read it out loud to you so that you can understand we are all human, and how we actually need to be cognizant of what we bring and what we have, and what we as humans need to understand in other humans. It says, "Dear friend, I'm addressing you as friend in this letter because if you are reading it, you are someone who works in medicine, someone who has offered help and healing to those who need it. That makes you my friend. I myself am a medical doctor, and I have had the dubious honor of having to perform multiple invasive interventions on patients in order to heal them. These procedures are usually associated with varying degrees of pain or discomfort on the patient's part, but I've always convinced myself to dismiss this rather easily, knowing that I was doing what I was necessary, hurting them a little so that I could heal them a lot. Recently, however, I've had the even more dubious honor of requiring an invasive intervention of my own in the form of an intercostal drain. After discussing it with someone close to me, I was encouraged to describe the experience from a patient's perspective, and in doing so, hopefully shed some light on consideration on what it means to go through the after of having relatively a stranger hurt you to heal you. About a year ago, I was diagnosed with bilateral thoracic outlets and cutlet syndrome, a condition so rare that it is recorded in only 1 to 2 people per 100,000 annually. That's 0.0002% of the population per year, if you enjoy math. In this instance, I do not. My parents have always told me that I was special, but I would have preferred that it manifest a little differently, if I'm being honest. All jokes aside, when I became symptomatic, I developed multiple upper limb DVTs in my left arm from the compressions occurring on my neurovascular bundle. And there was a legitimate concern for the same thing happening on my right and my dominant side. So to prevent this, it was recommended that I undergo a partial resection of my right first rib. I was warned that this is essentially entails breaking my first rib into pieces, and I was counseled on the associated risks as customary. Remember when I said that my parents had told me that I was special? It seems they were proven correct again. You see, developing a pneumothorax as a complication during this procedure is very rare. So rare that in fact it had only happened once before at the facility where I was admitted and theatered. I was lucky. It was lucky number 2. When I woke up from my anesthesia, the first thing I could remember was feeling a blazing red hot pain spearing into my back next to my shoulder blade. I started crying, begging the ICU nurse to rub my back for me, thinking it must be really severe muscle spasm. I didn't understand what was happening, and I couldn't lie down on my back at all as I attempted to angle my back towards the left away from the pain, only to find as I moved that I was restrained by something. I had known that I would have a surgical drain left in situ post-operatively, but when I looked down, there was another tube as thick as my thumb protruding from my chest. Moreover, I had sutures equivalent in diameter, so deep, the deep red fishing line securing everything in place, and it made every movement all the more excruciating for its layering of the experienced pain. From the searing sensation deep inside my chest to the dull ache of my surgical broken rib, to the fiery throb of the icy drain tubing as it neared in its exit point, to the biting sting of the sutures inside my chest where the drain had gone into my body. It honestly felt like some sadistic individual had heated up a fire poker and stabbed me with it, the scald starting to just beneath my clavicle and ending up at the tip of my scapula. Not to mention that I couldn't take a full breath and now required supplemental oxygen to boost. Over the course of the next few days, I slept fitfully, waking up every few hours from pain and requiring a cocktail of analgesics just to make it somewhat tolerable. What was also especially jarring was the feeling of the icy drain tubing grazing my lung with every inspiration and expiration. Internal organs were designed to be internal for a reason. Coughing was torture, seizing wholly impossible. But besides the pain, there was also the unrelenting fear gnawing at the back of my mind, despite the incessant pricking of the sutures in my skin, indicating otherwise. I had become deathfully afraid, excuse the pun, that if I moved too much or moved incorrectly, I might inadvertently dislodge the icy drain. The idea of having to endure this agony all over again was unfathomable. I was nervous, in fact, that when the D-Day arrived for the drain to be removed, I had to be given a ketamine infusion to facilitate the process. Needless to say, I don't remember much about the pipe coming out, except for the kind-eyed nurse who holding my hand and telling me when and how to breathe. Thank you, ketamine. I know that they say that doctors make the worst patients, and maybe that's the case, but it has been months since my surgery, and I can still feel the remnants of the fire poker in my chest. The sensation is different from the cold, constant ache left behind from the excised rib. It's almost as if I'm being simultaneously skewered by a flaming arrow and squeezed with its icy fist. I look down at my body and see my wayward scars dappled down my right side, and I realize that I haven't quite made peace with having them there, these perpetual reminders of what was necessary to help me. Helping me really, really hurt. I'm writing this letter to you, friend, because as helpers and healers, we can easily forget what it means to be scared and vulnerable and in pain. It is when we forget these things that we could harm instead of heal. I want to emphasize that I'm beyond grateful towards my surgeon and my entire multidisciplinary team, who were all acutely aware of the hurt that I had endured in the name of healing. If it wasn't for each individual's understanding and kindness and compassion, I would not have been able to recover the way I did. In short, I want to thank you, friend, for shouldering the burden of sometimes having to hurt so that your patient can heal. It is heavy, but it is worth it. My only regret is that you remember that you are hurting and that the hurt doesn't just go away because you have signed a discharge paperwork. So please remember, be gentle, remember to take care, and remember to never to stop helping and healing. And then I want to end off with a quote from our dear Rene Descartes that says, "I think, therefore I am, but surely it should be, I am, therefore I think." So think when you do stuff and why you do stuff and how it can be done safe and better. Thank you. Sorry for the technical glitches, but thank you very much. Sure, all quiet. I don't know. Is that good or bad? Any questions, any comments from anyone?
Yeah, I think let's just go to some questions, and if there's anyone who has anything that they maybe want to add.
I can add something that after we had our discussion with our crew last week, Debbie Groom, that most of you might know, some of you might know, had mentioned where we should be cognizant of deviations of normality. So as much as we want to change the system to fit us, we shouldn't deviate from what is safe. So just remember that as well. There's a nice article that I can share with you as well, Caleb, that you can share on the group about deviations of normality, how you want to change the system to fit the human, but it should stay safe. And where does that line, where is that? It's like an invisible line, but where is that invisible line where we go, oh, it's okay, we do it this way because it's easier and it's better, but is it safe? So where's that barrier? Where's that line?
So there are a few just comments sort of coming up, and then we'll go to Ryan. So I think one of the comments is just being in the friend's position and thinking about how you change how you interact with your patients. That comes from Chris. And then Amanda says, I think it's important for us to be mindful of our partners. And if you see that they're having a bad day, pick up something that they did well, comment on it, sort of help them stay in line with the right stuff and to shift their perspective of where they are at the moment. I think that's really, really reasonable. Ryan.
Hi, good morning. Just wanted to make a comment. I'm not too sure if it's pertaining specifically to the presentation, but the facility I'm working at, and also various other literatures have often spoken about just culture. I'm sure most of you have probably came across the term. To the it's Karine, or Miss Passon. Just a question
Yes.
I would like to ask. Do you think there's a place for just culture in the human factors? And do you, okay, so you can answer.
Apologies. Yes, no, definitely. That is part of when you said human just culture, my heart just raced. So thank you. Yes, it's definitely part of it, and it is just culture for the patient, but just culture for the healthcare professional as well. So absolutely, to be able to have that safe space where you can admit, I've made a mistake, I've used something wrong, and then to question what had happened so that you can change the system. Maybe you try to inject vasopressor into an A line. Why is that happening? Should the drug be warmed or labeled differently? Should the syringe be changed? Should that connection between the A line and the vasopressor be changed? So again, being able to admit and being able to open up and have that safe space to to just discuss it. And again, when you come for a flight or come for a shift or come for a whatever that you're supposed to, where you find yourself, where you work, to be able to say, I haven't slept well, and coming to the patient and the just culture as well. So patient safe culture as well, where we need to understand the background of the patient. As a geriatric patient, do we look at palliative care? Make sure that it's safe and just for everyone, for the patient as well as the healthcare professional. Absolutely. That's one of my components of my framework that I'm developing, is a just culture for patient and for the healthcare professional. Beautiful. Thank you for mentioning that.
I just wanted to add on to that. I don't think that there's space not to have a just culture in our environments. I think we need to be working towards being better, and clinical stuff is one thing, but to get better at the clinical stuff, you have to be able to have a space where it's safe for people to learn and grow and share. And without a just culture, I think we're just wasting our time, honestly.
Yeah, true. Yeah, I didn't even touch on the learning part, because if you don't feel safe, you won't learn and you won't grow. You might disappear.
There's another comment here, just as emergency care workers, we don't like to adapt to change. We're always set in our ways, and we always feel anxious when change happens, because it just feels like we might forget stuff. What are your thoughts on that?
Ooh, so that's a hard one for me because a big word that I describe when people ask me how I describe myself as constant. I like being constant. I'm a runner. I run very constant. I don't run faster with downhills or uphills. I run constant. So change is, for me, hard as well. But change is inevitable. And the more I work with people that are so much younger than me, they bring great ideas. And it bounces back to where I discussed the dinosaurs in the system. Be wary of becoming a dinosaur, but don't change because you feel it has to change. Try it, and then you can always go back to. If you haven't tried, you wouldn't know. But change is inevitable, and expect it, because when you expect it, then at least you can foresee it and you can plan for that.
Amazing. Just from my side, Karine, thank you so much for your time today and for the presentation. I think it was awesome. Word of the day is going to be human. Please don't forget to fill in the register. The link has been shared and will be shared again. And then just have a fantastic day.
Thank you, and thank you for the opportunity.
Thank you, Karine. Drive safe later.
Oh, I shall. Thank you. Bye.
Bye.
Thanks, Karine, and thanks, Caleb.
Thanks, Fernand. Nice to see you.
Yeah, thanks.
Thanks.
Have a good day, everyone.
Where do we fill our register?
Thank you.
Hi there. So if you look on the chat box, you'll see a jot form. If you open the jot form, you open up the cases, fill it in, and then the word of the day. So whoever asked about the register.